He did offend me with my
Speak.
nose.
We want eye contact with them, eye
Okay,
contact
we
with
are
each other.
rolling.
All right, welcome. Well, welcome everyone. Thank you for coming. Today we have a roundtable where we're going to be talking about Dailies Aqua Comfort Plus. I'd like to get started by just going through and introducing ourselves and telling a little bit about our background. I'm Kelly Nichols. I'm at the University of Houston, the College of Optometry, where I see patients, teach students, and focus on contact lens and dry eye. Art?
Thank you. I am Art Epstein, the editor of Optometric Physician, frequent lecturer. I am an associate clinical professor, adjunct clinical professor at Midwestern University, and I'm just opening a practice in Phoenix, Arizona, Phoenix Eye Care, and the Dry Eye Center of Arizona. So my clinical interests have long been contact lenses and ocular surface.
I'm Chris May from Coldwater, Mississippi. I have a two-location private practice there with a couple of associates, and we are a full-scope rural practice where we see a little bit of everything. I'm also adjunct faculty for Southern College of Optometry.
I'm Crystal Breimer, and my background is in private practice. I've been practicing in Wilmington, North Carolina for 13 years, and my interest is contact lenses and dry eyes.
Fantastic. Well, welcome everyone. Well, I think we're going to just get started by jumping into a discussion, since it's very salient to all of you, of the tear film, and kind of how the tear film has become increasingly important over the last decade in terms of how we're managing our patients in both health and disease. So I'll start out with you, Art. What do you think about the tear film? Why is it important?
Well, you know, it's interesting, Kelly, and I know you share my love of the tear film, and I say love in a very emotional way, and I sometimes feel like I live within the tear film, like I'm submerged within it. Many years ago, when we first started fitting contact lenses, and I go back a fair ways, I think that was not even a consideration. We didn't really think much of the role of the tear film. I came from the time where we fit PMMA lenses, and certainly with soft lenses, some of the complications.
What lenses?
Oh, yeah, those are the old hard lenses. They actually were hard. In fact, well, it's a long story that I won't get into. But when patients called them hard lenses, they were actually hard, and unfortunately, that doesn't sound too well, in terms of getting patient affection. So, soft lenses really revolutionized the way we interface with patients, but it didn't take long before we realized that there was a lot more to the equation. And one of the things that I think has been a constant area of growth is the recognition that the contact lens has to not only be compatible with the tear film, but exist within this extremely complex surface. And I think our understanding of the tear film has increased dramatically, in part, because of your really exceptional research and focus in that area. And we now recognize the tear film not as discrete units, but really as this complex intermesh of fluids and substances. And you take a contact lens and you try to get this contact lens to exist within that area. And you realize the difficulty of it, and that's why we're looking at some of the newer technologies and newer strategies to increase the compatibility, and also taking the understandings we have of the ocular surface and the tear film and applying it to the design of contact lenses. So, I mean, to me, that's really the most fascinating thing, and it really become my primary focus because of the exciting aspect of that.
Mm-hmm. Well, Chris, in private practice, I mean, I think something that Art hit on was really interesting. I mean, over this length of time where we've been fitting contact lenses, when do you think you kind of became aware that the tear film was important? Because I think back to my training, and I don't really remember that many discussions about how the tear film interacted with the contact lens. I mean, so can you recall a time in practice or in training where...
I was actually just thinking that exact kind of thing of when did it
Happen.
go from this very discrete three-layer model that was going to be so easy to manage, because there were only three things that could mess up, so just fix whichever one of those three is wrong, and the rest of it drops into line. And then somehow became this giant polyelectrolyte matrix that organizes itself in a few nanoseconds and holds itself together for a few hundred times that. And it's amazing that the tear film even works. And unfortunately, I think it's when the tear film relationship became adversarial for us too, where you're trying to get what do we have to do with this lens to make it work with the tears, or can we manipulate it, or it started to become more of a fight. And I think in the last few years we've maybe come through that phase, and now we've learned that it's something that we're going to have to work with. And I think the biocompatibility discussion comes there.
Right.
And it's that continuum in the last, say, decade or so has been really interesting, changing our perceptions, and also recognizing just how unbelievably complicated the system is. I mean, it's the first layer. It's the first thing like strikes. We spend all our time manipulating it, but if that tear film's not in place, everything that we did was for naught.
Right. Well, that's something you said is really interesting there too, Crystal. So do you think our colleagues recognize that the tear film is as important as we're sort of, I mean, I think we sort of recognize it is, and it may be that we recognize it is in the problem cases or after it becomes an issue, but do you think that the tear film is thought of even in the initial contact lens fit, or in the patients that don't perceive any problems by our colleagues, or maybe they don't recognize it at all? What are your thoughts?
I definitely do not think it's thought of as much as we think about
Yeah,
it.
I think there's probably
and I
some truth
think,
to that.
like you said, it would be more of, all right, if I've got a problem patient, I fit them in all these lenses, what's going on, and then they look further. And I would say it also depends on how closely they pay attention and relate and are interested in the research. You know, it's especially over the last 5 years, and just new information and studies on meibomian gland contribution and dysfunction. And if you're in tune with that, I think then you start looking for it clinically, and you start realizing the impact it has, and start being proactive even. So,
You know,
Yeah.
Kelly, I was just going to interject in. They really stimulated a lot of thinking, both Chris and Crystal. What's really interesting, and I think you probably relate to this more than most, our interest in the ocular surface and the tear film, I think, started when we recognized that patients were having end-of-day dryness. And so we really considered dry eye a separate entity unto itself, and contact lens fitting a completely separate discipline, which had very little to do with one another. And then suddenly we began dealing with more and more patients who wanted to wear their lenses for longer and longer periods of time. And then we had this end-of-day dryness issue, and we began to look for ways of solving it. So new lenses came out, and we introduced new lenses, and we introduced new lens care products that were designed to increase surface wettability of the lens. Then all of a sudden we started looking at how that interfaced with the tear film and what the role of the tear film was. So I think what's interesting is that the cart drove the horse here, that we now recognize that an appropriate contact lens fit and a good clinician who works with contact lenses really has to understand the dynamics of the tear film and all the subtle nuances and the cutting-edge developments that occur, just to make sure that we can keep patients in contact lenses and, in fact, hopefully drive and help drive the industry towards better lens designs and more functional lens designs that do work within the tear film.
And Art, I think in addition to that, as far as what spurred our thinking and inspired us to move in that direction, not just them wanting to wear them longer, but the visual demands they have.
Right.
And the
That's
fact
great.
that their computer time is just off the charts, and
It's more like
consuming their
life
day,
demands they have.
everything, their schedule, and the environment, and differences in allergies and dryness.
And when I started, there were no computers. So, you know, we literally sometimes forget that, you know, this has been a reasonably short time in the overall evolution of mankind, but in terms of visual demands and things like that, you're dead on. What a
Well, and
tremendous difference.
our phones, our mini computers that we take with us everywhere. I mean, I think, and kids with their interaction with media, it's just, you know, just 24/7. So, and it wasn't like that before.
Yeah, what would have been a computer job, you know,
Do
before
you-
it was only
yeah.
a programmer, now is
It really
everyone.
is everyone. So
Exactly.
I guess I'll ask this to all of you. I'll start down with you. Do you think a patient understands that there's a tear film and that it does anything at all? I mean, when you interact with your patients in practice, are they surprised? Do they nod? How does that?
I definitely do not think there's patient awareness. I
Yeah.
mean, they're aware of the cornea, the contact lens is sitting on there, but nothing about the intricacy of that
Of the layers.
interaction and the layers. When you take the time to explain it to them, I think they appreciate it, and I think it puts it in perspective for them, so that they know that there's not a quick fix. There's not a perfect solution, but we can work together to find that ground where you're asymptomatic in most places.
Right. Do they enjoy hearing about the tear film? I mean, when you say there's water and a whole bunch of hundreds of other things in there, like, oh, yeah, nice to hear, or is it, does that push them to further understanding of technology, since most everyone is technology driven? What do you think?
I think they don't necessarily enjoy it, but it gives them perspective. So even if you only have a few seconds of discussion on it, it lets them understand the complexity. And that's the goal there, is to say, okay, it is a very complex layering and interaction, and the way that it interacts with different materials is different. And so that's why it's important that you follow my recommendations on lens care, and you follow my recommendations on the lens that I'm prescribing, because it all works together.
Right.
I think definitely there's an appreciation for complexity is probably the key to success too, because as the patient, especially the borderline patient, is probably the landmine dry eye patient, where they don't realize they're dry until we put the lens in place. And then they come back complaining about us and our lens that keep drying out. And so we have to have this conversation of what's really happening underneath that, even though they may have changed any number of factors along the way, where they've started taking antihistamines, switched their
Right.
solutions, and,
Medications and all
and had
that.
18 Diet Cokes and a cup of coffee instead of some water.
I resemble that comment.
That's actually is a very interesting approach, different than the way I approach things, because I'm looking for opportunities to change the patient's perception. I think for patients it's very simple. They come in, they want to see well, they want to be comfortable so they can wear their lenses as long as they want, because they're there to change their interaction with their environment and change their appearance, and they want to be safe. So, and I think they believe that my expertise will keep them safe, and the rest is performance. Whether I can adapt something for them that will change, their interface in a way that they can wear without any issues. But I also look at the tear film, maybe because I'm a storyteller by nature, as an opportunity to educate them in a simple but direct way, and share some of the wonder of what I see and what I experience with them. So I often will take a minute or two to talk about how complex the tear film is and its
What do you
viscoelastic
say?
qualities.
Describe what you say, or what what level of understanding you hope they have.
Putting me on the spot, are
I
you?
sure
So,
am. I
no.
need to get to the layers of the tear film somehow, and you just walk right into it.
Well, actually, I have a habit of doing that. So, what I find actually fascinating is if you tell someone something they believe to be true, or they observe in their normal existence. So, for example, we're all sitting here upright, and if you think about it, if we took some fluid and threw it on against a wall or on a screen, it would just literally roll straight down. So our eyes are shaped in this convex shape, and yet the tears stay in place. And they think about it for a second, and there's recognition that that's a true statement. And then I say, well, think about that. How is it that the tears stay in place? And you can go out running. In Arizona, it's hot as heck. It's really dry, and the tears stay in place. I said that's because of the elegance and complexity of this tear film that evolved over time. And the surface of your eye is really designed to protect the inside of the eye, and it actually repels water, but yet it's adapted to keep the wet tears in place, and it produces a structure that is protective, that has this viscoelastic quality. And of course, being a native New Yorker, I use the viscoelastic international sign. And then at the outer layer, there's this oil which prevents evaporation, and the contact lens I'm fitting is one that I chose because it works within that really elegant system that evolved over eons, and at the same time fortifies it. So I went to a tremendous amount of trouble to choose a lens that I think will work really well for you within the context of this beautiful system, and I think they get a sense of, if they're religious creation, if they're very pragmatic, maybe just the complexity of evolution, and I think it inspires them, and even more importantly to me, it bonds me to them, and perhaps keeps them stuck to me as a practitioner. So, and that's what I want. I want to establish my brand with my patient, and differentiate, the experience that they had from what they may have had in the past and what they might have in the future if they leave.
I like the complex and elegant components of what you're all saying about the tear film. I think, we used to think of it as the 3 layers, and now we know there's much more going on there, and certainly having a discussion with patients about what it does, how it protects the eye, how it nourishes the eye, and provides for that, of course, a smooth refracting surface, which is so important to us and them in terms of vision. So, very good.
Well, Kelly, I'm going to apologize for interrupting.
Sure.
You just hit the nail on the head. One of the epiphanies that I had a while ago is, what's the purpose of the tear film? If you think about
Right.
it, what's the whole purpose? And it is really something that's consistent with our evolution, is to give us absolutely clear and sharp vision, and everything else falls into place after that. Because if we can't see predators coming or forage for food, we don't exist. So the tear film structure is all about vision. And in fact, that's really what we're talking about now.
Well, that's what Crystal mentioned first, too, that vision is something that patients come in, they expect and they want, and that's why they're there ultimately. And I think sometimes when we get into these discussions about the tear film and we break it all apart and we talk about disease, we forget about, really, vision. It's there to protect, it's there to nourish, it's there for vision. And, and I think we also, especially us, tend to think about more so what happens at the end stage, the disease component of it, when it goes wrong. But I want to take a minute or so to talk about that, just like the normal patient and their normal tear film. Does that exist? I was just thinking as I was hearing this, we tend to, when it's a problem, but when you ask the questions about symptoms, we know that 75% or more of patients that wear contact lenses have some symptoms. Now, if you ask them, if I ask all of you, when you're wearing your lenses, do you have any discomfort? You're probably all going to say, well, yes, yes, yes. So it's kind of obvious they're going to say something, but in your experience in your practices, start with you first, Chris. What are you hearing from your regular contact lens patients in terms of comfort?
Comfort is, for a contact lens patient, probably the biggest catch-all bucket that we could possibly create. We say, are you comfortable? And they'll say, if they say yes, then they mean I'm able to wear them as long as I can possibly wear them before you started yelling at me. But to the other side of that is, if they're not comfortable, they use the word dry, and then they just start throwing all these things. But to us, that dry is a very complicated dry. That means a lot of things. Same way when we tell them they have dry eye, they assume that they don't have tears, and they'll go, well, I cry all the time, and I have tears. But one of the biggest things for me that changed where I look for it, in particular, because asymptomatic patients abound.
Yeah.
And as you're looking, even clinically, like you said, by the time we're to that disease process phase, we're looking at it. But refractively, it's amazing the number of times, particularly with students, where they've been all over the place. They come out of the room after refracting a patient. It's taken 25 minutes. The student's in a cold sweat, ties undone. And I couldn't get anything stable. I just couldn't, we've got a +1/4 at the refraction after all this. And you go in, and that patient, as they go to, can you see this line? Yes, no, yes, no, got it. And you're going, I haven't touched a thing yet. And they hate, I hate this machine. And you realize, what's their life like? When they're sitting looking at the computer, it is literally yes, no, blink, I've got it, nope, it's gone again, or driving with the air blowing on it in the heat of the summer going, I can read that sign, no, I can't again. And that's a very frustrating life. If your tear film's not cooperating, blinking 8,000 times a day gets really annoying.
Right.
When you don't know what's going to happen afterwards.
Well, some of the studies that have been done in this sort of area have looked at breakup time, so non-invasive breakup time over top of the lens. And when you hear that information, or as you've looked over the papers that we kind of passed around, does that influence you or your decision, or how? Let's talk about what you think about breakup time in a contact lens patient for just a couple minutes. I'll start with you.
Okay, I'm actually going to add to your last question, and I'll get the breakup
Okay,
time, because
sure.
it was a phenomenal
Fantastic.
question. It was really, it may be the pinnacle of questions for the whole roundtable.
Good, what was it?
Well, no, actually, you essentially said, do you see dry eye, as
Oh,
something that
in the-
affects in the context of a normal patient
Right.
versus a patient that has disease? And, it's something we don't think about, because we're programmed to think healthy, diseased, healthy, diseased. And then when you put a contact lens patient in the middle of that, the contact lens patient theoretically is healthy. And how can they have dry eye disease if they're a healthy patient? So I think what you alluded to is this continuum,
Right.
that the patient goes from asymptomatic and with no real physical signs, at least that we can measure with current technology, and we would consider them to be a completely healthy patient, to a patient that may be symptomatic but shows no signs, to a patient that we would consider to have some issues in contact lenses to a patient where boop, we have crossed over that border with a patient we're talking about disease. And then suddenly our dry eye management and surface disease management skills kick in. We're thinking about medications and other things to the point where the patient's having a conjunctival flap or a torsophy or something, So, there's a long spectrum. But I think what's interesting is that we're all approaching it in a much more holistic way and saying this is a continuum, and we can intercede earlier on during that continuum and prevent the patient from experiencing adverse symptoms and prevent the patient from having a bad outcome with contact lenses and ultimately prevent the patient from actually experiencing frank disease. And I think that's one of the most, absolutely wonderful things. The science that you just asked about is another bit of insight into allowing us to understand the patient's experience in a tangible way for us that we can use to affect change and to make selections in terms of what is best for them. So non-invasive breakup time is a useful tool, and it gives us some insight into what the lens is doing relative to tear film stability. And do no harm is the mantra, the agreement we make with society as part of our training and our education and commitment to providing care. And to me, a improved breakup time where the lens is clearly not affecting the ocular environment is do no harm. So I always look for a contact lens where the scientific elements of it suggest that this lens was formulated properly, designed properly to minimally impact the ocular environment. So I think that's very helpful for our colleagues.
Well, I want to also then have you kind of do both, because I like this concept of the continuum, because I like to think, what percentage of patients, so we have all these patients that are somewhere in this continuum, and I still want to kind of point out that I think that there are lots of patients who are comfortable and are on the good side of that continuum, and would you agree with that in practice? We'll start there, and we'll get to the tear breakup time stuff too, but talk about the continuum or your thought there. This might be something new to you. You've been doing it, but now you're thinking about it.
Exactly.
Yeah.
The more you think about it, the more you start going, and in the continuum, where's my
Break point.
dotted line? Where am I going to say, okay, now officially you're here? And I think especially when you're looking at break times too, there's not one rule.
Right.
Why isn't there one rule? We should be able, we like to put things in the boxes, and I would like for there to be, I'm sorry, it's 6 seconds, you are in trouble. And if you're 8 seconds, you're not in trouble. Or within the non-invasives, you're looking at this 15s, and we know, yes, if they're longer than that, they're going to be a lot happier. But there are patients existing all the way along that continuum in every single phase, and also moving along back and forth of it as seasons go and as lens wear goes, and depending on what we've chosen and what we're doing. Or if they had a coupon for something different. And that makes things very complicated. And I think that lack of predictability is part of what we don't care for as practitioners. We want them to fit in our diagnosis box. They are either sick or well, nowhere in between. And while do no harm is our ideal, once we put something on the ocular surface, we've changed it. It's kind of like the uncertainty principle. We've affected it. And we can't be ideal, but we certainly can be far more elegant than we were in the past. Back when people put PMMA lenses on us, it was strange.
Dinosaur years.
And when you're talking about the continuum, you're saying, I wish there was a line and clarity there, but also for the general practitioner, it's not just about deciphering where the line is, it's about putting forth the effort to even think about
the
it.
continuum.
Because let's think about this. You've got a patient, you walked into the exam room, it says 20/20. They must be 20/20, but what you don't know is that they had to blink several times to make that 20/20. Technician wrote it down, we move on. The patients aren't complaining because they think that it's normal. They think that it's appropriate to feel their lenses at the end of the day or to have to blink several times. And when you sit there and you actually make that effort to start asking the questions and say, how's your end of the day comfort? Is it different towards the end of the month or whenever it's time to throw your lenses away? Is the vision different? And the response is so consistent. I hear it all the time. They say, well, yeah, but I know it's time. So it's unfortunate that that's the expectation.
But what a gain when you go in and make a change to the patient that didn't think anything was wrong, and you make an adjustment, let's do this, let's do that, and they come back. They're now
loyal for life.
so loyal.
Yeah.
Exactly.
Right.
But the thing
And
is,
that's
I
what
think
we
a
do.
lot of times that's not happening because we're not taking the initiative and the time to ask those questions when they don't complain, and really looking at it in that full spectrum mode.
Well, speaking of that and asking those questions, so what do you say, I'll ask all three of you, what do you say to your patients when you look at the record and it kind of gives an indication that they're, contact lens happy and they're there for an eye exam? When you walk into the room, do you, what is your phrasing to the patient? Because I've heard there's some, in some instances it's so limited that there's no information to be shared there. So if you have some tips or that what you might say that would help our colleagues maybe inquire a bit more, that would be really helpful. So we'll work in reverse, yeah.
I go in, and for this part in particular, I sit face to face and I say, tell me about your contact lenses. How are they feeling? And I just ask probing questions. And they say fine. Then I start saying, what about at the end of the day? What about at the end of the month? Is there a difference from the beginning to the end? And they start thinking about it. Are there days where you feel like you have to take them out before you really want to? Do you have
Right.
to put drops in?
I'd say fine is the most dangerous word in a contact lens practice, because we have dropout. We're losing patients. They're
Right.
not fine. So they're saying fine at that moment, and so probing is a great way. We fish for complaints.
And you do that.
Most of the time, while you can do questionnaires, things like that, no matter what we do, it's not the same as, like you said, sitting face to face, looking them square in the eye and saying, are you sure you're fine? I mean, is it,
Yeah.
does it do this? And you may have to give them a couple of examples. And it's amazing the number of times where you give 2 examples and they go, all of a sudden
yeah.
these complaints come out
Yeah.
that weren't there a moment ago.
Well, and when you do it face to face like that, it gives them, it puts them on the spot, but it gives them that impression that you're listening. So this obviously must be important. If you're
Right.
not, you don't have your back to me on the computer, or we're looking at a chart, you're looking in my eyes going, are you sure? Then it must matter.
Right.
So it gives a sense of gravity to it.
It
I
also
think.
empowers them they don't want to disappoint us. Well, last year they put me in that lens. I liked that lens. It was okay. It was better than the old one that I had to
Right.
replace every couple of weeks.
I think there's a lot of complacency in fine, and so we need to, I think, keep reminding our colleagues and ourselves to not take the easy route and say, okay, well, good, fine, let's move on, and kind of continually see whether or not they're in the best modality for them.
I think it's sometimes we forget to mix in understanding of patients and how they respond. To me, patients are very digital. It's a yes or a no, and sort of a patient comes in and how are you doing, and they'll go, oh, I'm okay. And what goes into that okay. Crystal sort of alluded to it. The patients will put up with a certain amount of discomfort if they really want to wear their lenses. But the truth of the matter, to me, it's very analog. It's shades of gray. It's not black and white. And so I understand that about patients, and I think probing and engaging them in conversation, it doesn't take very long, because you can ask some very simple questions. You can ask, are you comfortable, during the whole day, or are you comfortable at the end of the day? Do you sometimes want to take your lenses out and sooner than you feel you'd like to? But more importantly, to me, it's not just meeting their needs, but anticipating their needs. And change for patients is critical, and technology and my understanding of it is critical for the patient, because they're coming to me because I am the expert. So it's important that I give them the best possible alternative that I can. I have patients that come in and they have a brand new iPhone every time a new one comes out, and yet they're wearing the
complain
same
about, yeah.
old, conventional 2-week lenses that they were fit in, 10 years ago. And if I'm not explaining that, hey, I have some new technology that will make a difference, and explain that technology to
That's
them,
really
I'm
important.
really not meeting their needs. And
Nope.
again, I'm not really differentiating myself as an expert, and that's not a win for anybody. So, treating them, understanding the digital nature of the patient, converting into an analog discussion, and then making them aware of the best possible alternatives, or reinforcing the alternative that you did choose that is still state of the art, is very, very important, because they want that reassurance from
Right.
an expert.
Your iPhone 4S is still okay?
Yes, but
No,
only because I
I-
like my unlimited
Yeah.
plan. So.
I think there's really a good message there, because I think we are where they're not. We find out about an iPhone because it's so plastered everywhere when a new one's coming out, and you can't miss it. But they can easily miss technology about contact lenses because it's not really directed at them. It's directed towards directed towards us as practitioners. Sometimes it trickles down into direct-to-consumer marketing, but maybe not even in the way that usually is that's usually targeted towards new fits or new patients, not so much changes in technology, I would say. And so we're the providers of that information for them, and if we don't do that, then we're probably missing a bit about our job.
You're dead on. We have to recognize that patients have iPhone envy. I can look over there and I can see this person has an iPhone 5, and I know I just sort of have an iPhone 4S with a big battery. We don't have contact lens envy because no one can tell that the lens that they're wearing is technologically advanced. Unless we tell the patient that and actually get the patient talking about it to other people, we can actually create contact lens envy.
That's actually one thing I think that dailies are uniquely capable of doing.
Right, I was going to get there.
You can create that where
Exactly.
somebody goes, "Hey, I threw mine away," and they go, "Well, no, why'd you throw it away?" I've got another pair. I'm ready.
And with this technology, absolutely, there are things to be envied.
Well, you think about it in the optical, and you want that patient walking out with the top of the line frame with all the bells and whistles because people can see it. You don't want their faces turning green. You don't want their nose pads falling off because then you get a reputation for
Taper
that
around
kind
the
of
middle.
product. But in contact lenses, we don't always look at it that way. But if you start doing that and you get them excited and you explain the technology in a way that they're inspired and they know they've got the best thing on the market, then they are going to go out and tell people about it.
Change the dynamic.
Yeah, let's talk about the daily modality for a little bit here because I think it's really critical. So far, when we've described these patients that we're seeing, we're typically describing patients that are on a non-daily method because I heard both of you, actually all three of you, talk about how are they at the end of the month, how are they at the end of your wear time, which indicates more than a day. So how is it that you incorporate dailies into your practice? And and I also want to talk a little bit about in other countries, daily wear is much more prevalent than it is in the United States. Although it's, I think, changing here more dramatically over the last 5 years than it has been in times past. But why is that? What are the barriers of daily wear? And so sort of barriers to daily wear and benefits of daily wear that you see. Any one of those things you want to highlight? Let's start with you, Chris. No, you're going to go middle. I'm always starting with you.
She
so.
threw you off, didn't she?
Yeah, I did. He was.
She looked at me and went to you.
Yeah, I was going to say, hold on
It's
there,
probably better for her
Art.
to not do it.
It was like
You'll have your turn.
it was like a pass, but
I think when it comes to the modality in general in the U.S., one of the things we're seeing a little lag behind. Of course, dailies came out in England 98, 99. And the Japanese have embraced it a lot more. I go to a lot of it looking at printer cartridges. Printer refill cartridges sell in America to be able to refill your own disposable ink cartridge. It's a disposable ink cartridge, but we want to use it one more time. There's a thrift concept there that dailies do have to push against, and it depends a little bit generationally. I think a lot of that can come into play. Convenience is another huge factor. But if you deliver on comfort and vision, the rest drops in line. I do think, particularly when it comes to the American uses, one of the things that their instinct is to say, well, that I still have value left in this. But what we have to do is teach them that price is not the concept. Value is the concept. And while the lens is disposable, move on, let it do what it's built to do. And once we do that, once they experience it, it's kind of like seeing the mountaintop. They go, this is so easy, this is so much nicer, I don't have to worry about all these other things. Particularly the symptomatic patient. That's the patient where they can come back in after only a couple of weeks just absolutely in love with the new modality. And then a lot of times the question is, so are these brand new? These just came out this year? And we
Yeah.
kind of,
Yeah, see, I feel that's and I'm just as guilty. Yeah, I feel that sort of reactionary. It's like, well, why are we thinking of it only for somebody who then has a problem? I think this is a little bit of our mindset that we need to kind of get around. I don't want to say more about me, but what do you think? I mean, how are you placing that?
There's
in
no doubt
practice?
that price is an obstacle. But I think in general that most patients are more concerned with finding the greatest value than they are the cheapest price. And so that puts the ball in our court and the responsibility on us to create that sense of value. And we do that by talking about the health benefits of it and the convenience. But I also think that a lot of this lays on our staff, because it's easy for us. We know the benefit. We know it innately, how much better it is to have a clean, wet lens every single day. But staff doesn't know that. So, I sit down with them and I say, all right, let's talk about this. Let's list out all the benefits to having a clean, fresh, wet lens every day. And then let's list out the patients who can benefit from that. And when you do that, you've got 20-some things up there. And when you start thinking about it, there's no patient that can't benefit from it.
Right.
And so it changes their perspective. It gives them confidence. And it allows you to have the conversation from the minute the patient walks in the door, or sooner, until they've left the office. And I think that helps them get excited. It helps them overcome the price barrier as well.
So do you, I don't know what the makeup of daily versus other modalities is in any of your practices. Are you starting to think more about just starting with a daily, presenting that as first line option, or how are you, is it a first line choice for some patients, or how are you feeling that out a little bit in your practices?
It's become my new wearer lens of choice,
Okay.
especially in children. One of the biggest reasons there is just the torn lost lens factor, because one of the first
they
parent
always drop
questions
them,
is,
yeah.
number one, is it safe? Number two, what am I going to do when this thing goes down the drain, or what are we supposed to do? And they have a concept of a very different lens. They're thinking of one lens that has to go a lot longer.
Right, like it used to be.
Once we go, oh, it's not a big deal, especially for sports, throw a spare pair in your bag. You can, when you're traveling, you've got them. And there's almost like a sense of relief on the parent's face. Oh, thank goodness, we're not going to have to go through this. Oh no,
Drama.
do we have to order
Drama.
another one? Drama, and with
Yeah.
teenagers especially.
Exactly. A teenager down the street got fit, and her mom called me and said she just got our lens yesterday, and she she was putting it in, she
It's
can't
gone.
find it's gone.
No problem, there's another one,
Yeah.
and that is very interesting. One thing that we used that was a little different in a rural practice, the pushback can be substantial on cost. And
Describe rural for me. I'm
So,
curious what that means.
we're about 35 miles south of Memphis, so our practice has more patients than our county has residents. So to give you an idea of where we're drawing, so it's a little bit different, very agrarian or blue collar type of work. And so when it does come to delivering, our patients are very aware of value, and they use price in that calculation, so we have to make sure that they understand it. But one of the things that was very interesting was transitioning our temporary wearers, so to speak, the kids and our part-time wearers. But once they got out there, they were talking, so we did get some lens envy. But equally, we found that our 30 packs sell just as consistently as our 90, because we have some patients that are more worried about cash flow than cash outlay. And we had to respond to that. because we
they'll
had
do
this,
it. They just need to do it in a slow way.
Well,
and
we-
continue away. Yeah.
front desk, we came up with this. We've got
Yeah.
a rebate system, and we handed a patient a stack of boxes, and this is wonderful. I will see you next
Next
year.
year.
They got to check out and went timeout.
Right.
Yeah. And then sometimes they throw everything out rather than starting. So it allowed us to have a way to go, you know what, let's start this. We call them training wheels. So literally, teenagers hate it, but especially for young wearers, these are your training wheels. These are, we're going to start you out until you get the hang of it. And it seems to be, once they do that, it's very comfortable. The lens delivers, and then there's no issue.
Right. All right. What about
See,
you?
that's actually a thing of beauty, because
I like it a lot.
I think the disconnect has long been the practitioner, and there are several reasons for that. I think the first thing is we sometimes forget that if Otto Wichterle had designed a single-use lens initially, we wouldn't be talking about anything but single-use lenses, because what would be the point of having a conventional lens? We now have a conventional lens mentality, and certainly, being an astute practitioner, different lenses for different patients. You need to come up with the best choice for the patient, but not based on wearing schedule, based on visual function and the ability to meet the patient's needs. But you really have to lead with a disposable lens. The problem that I think we have as a community is that not only do we have a non-disposable mentality, but optometrists are so patient-centric and so self-deprecating that we automatically become a patient advocate, and we misconstrue need for benefit, and we tend to steer patients away from what would be a better choice for them. So we end
Because
up...
we're projecting on them.
We're
Yeah.
projecting
Our
their
own
ability to afford
opinions.
things and their value.
Yeah.
Now, what you did was absolutely sheer brilliance, because you adapted the best choice to their financial need and made it easy for them to do what you know is in their best interest. So we tend to really derail that equation. There would be no conventional lenses if everything else was equal. If we had complex lens designs, if we had, torics that went up to minus 12, sills, in a daily disposable.
Daily disposable, right.
That's what we'd be using.
Yeah, I agree. I mean, I think we are. I think we project our own feelings of what the patient would want. Sometimes it's going to be hard for our practitioners and our colleagues to get out of that. I mean, the best example of that, I think, is those Keurigs. I mean, it's the little cup of coffee that they probably drank in your waiting room, which cost more per unit than wearing the lenses for a day, and they have no problem drinking that coffee and throwing away that pod.
Absolutely.
So, but it's and I think that we forget about those sorts of analogies when they're going to leave and go buy a Starbucks for $3, and yet we feel our conversation with them about the cost or value relative to daily disposables is something is uncomfortable for us.
And part of it is we don't really see our own value. We tend to self-denigrate it, and that's because our nature, we're just so tied to our patients instead of really understanding how important we are in that equation. We'd have no trouble giving them Keurigs, without even hesitation, because we drink it and they drink it, and we really need to get behind that type of thinking.
Yeah.
But Kelly, you hit on it, relating it to something they're already spending their money on, that they can do without. So in a rural area, it may not be for Starbucks,
No.
but it might be a Coke.
Exactly.
2 Cokes a month at the 7-Eleven, or it might be a Big Mac once a month, and just taking that, whatever it is, that $4 a month difference or $5, and breaking it down and making it relative.
And which is healthier, the Big
Exactly.
Mac or the
That's
daily
what,
disposable?
that's what I mean. It's got to be something they're already spending their money on, which is going to be different for every single
They're
patient in your
commodity.
chair.
So-
But it's got to be something that they can do without.
Are you suggesting that we can actually combat the war on waste oil by
I
recommending daily
think.
disposables?
By creating lens envy.
Yeah,
I think
there
we
we
can
go.
do
That's
that.
right. Yeah.
But I think, too, it's still tied in with the price barrier, but I think from the average OD view, it's also a time barrier because they expect this pushback. They expect they're going to have to spend time on it, and they may feel like, I'm behind, maybe next patient, not this one. I need to move.
Well, I think it's interesting, like you suggest, is starting from the get-go, because you never have to have that discussion if you've started with dailies.
Right.
Conversion is
Yeah.
far more difficult
Right.
than the initial.
Right.
No different than it would be trying to convert a rigid patient back over. I mean, most of us would
Yeah.
go, oh, no, I'm not wasting my time doing this. I'll end up drowning in it.
Right.
But it is definitely can be a lot more difficult to try to change them if we start them out that way. And they can always go to something else if it's whatever fits their needs the best.
Right.
But
Sure.
once they try it, though,
How about
it's very
that cost
interesting.
discussion about, well, you have to buy solutions if you're, and, maintain your case and all that in terms of the convenience and cost relative to the lenses. If you add all that together, aren't they almost equal? Do you use that, or is that not valuable? Any of the three of you?
I don't use it. Part of the reason was if, for some patients, the absolute cheapest modality is abusing a lens. We just can't compete with that. If I'm going to stretch a lens 4 months longer than it's supposed to be worn and not use any solution or barely top off with what I have, that discussion is a moot point for the patients we were trying to convert it. A little different when we started looking at those patients as solution non-compliant. So no matter how many times we said we wanted you to do this, once we said, okay, what's another way for me to adapt this? So we lost out when we tried to show them the yearly savings.
But, it also raises the issue of, you're the captain of the ship. I mean, why does a patient come to see you? Patient comes to see you because you have expertise above and beyond that of a normal person. They have inherent trust in you. Their mere presence in your chair is indicating a level of trust. So when I make a recommendation or prescribe something for a patient, I wouldn't discuss which antibiotic I'd use for them, because I choose what I think is best, and I think they trust that I'll do that. I think we get so caught up in, sort of making excuses and offering price comparisons. If they want price comparisons, I know a great used car dealer where they can actually decide what's better, an old Ford or an old Chevy. But, for me, I'm making a recommendation based on their best needs. Now, some patients will push back because, perhaps they can't afford it. But generally, that's not a discussion I'm having. That's a discussion the staff is having. And if you empower the staff
That's
to
right.
deal with those types of problems. It keeps you where you belong, which is the authority
Mm-hmm.
whose best interest is focused on the patient, rather than the less pleasant aspects of their daily.
The dollars,
Yeah,
yeah,
dollars,
associated with it.
exactly.
Well, we got off task a little bit there, but that's okay. We talked about the tear film. I want to talk a tiny bit more about the tear film and the contact lens and how the contact lens interacts with the tear film, and perhaps since we've mentioned the unique nature of a daily lens, and the designs and unique properties, we'll get into that with this particular lens that we're talking about today in terms of compliance. So you mentioned that, we'll keep that in mind with this lens in a moment, but let's talk just very briefly about, we started down the road of the non-invasive breakup time. And the studies that have been done have shown, that daily lenses in particular, and this lens in particular, offer some benefits in that arena. Now, you see the data, the non-invasive breakup time. I'm guessing, maybe you do it in your practices, but I'm guessing maybe you don't. You might do regular tear film breakup time. When you see that data, does it influence you in a positive way? You mentioned that it did. Not necessarily do you need to repeat that on your patients or use that in care, it sounds like. That then indicates that lens has some unique properties. Is that an appropriate interpretation of that sort of data for you? What else what else influences you from some of those studies we looked at?
Well, no, actually, that's a great point. I think there are things that you do clinically to evaluate an individual patient, and there are things that you look to the peer-reviewed literature
influence you.
as
Mhm.
essentially a gold standard of information that allows you to make educated decisions and choices for prescription or recommendations. So when I look at the performance of a contact lens tested in an independent study, and it doesn't have to be an unsponsored study, as long as the person who's conducting it is credible and the study design is reasonable and well done. What I do is I take that and I assimilate that information into my overall scheme of what I'm going to prescribe for a given patient, and also into my understanding of how the lens works. So I'll look at the mechanism of action of a lens, what elements it contains, what elements it elutes, or what structure it has. I have a sense of how that functions within the tear film, and then the studies just bolster that for me. And for me, that turns out very helpful in terms of communication with patients, and also with reinforcing my own belief in the efficacy of the product. So, whether it's non-invasive breakup time or whether it's other elements of tear film stability, to me, that's very, very valuable information.
So the tear film stability matters to you.
Tear film stability is absolutely key, because essentially we understand how contact lenses function when things go wrong. We understand that the polymers that are used in manufacturing lenses are best when they're kept hydrated, when they're kept enveloped in a shield of tears or moisture. And we know, if you look at all of the research and all of the formulations and all of the developments that have been done over the past few years, the modern times of contact lens design, we see that a lot of those strategies have been developed specifically to maintain surface moisture and to minimize contact with the hydrophobic atmosphere. We want a lens that's exquisitely hydrophilic within the hydrophilic tear film, and we want a lens that's not going to disturb the normal architecture of the tear film, and we want a lens that's not going to interfere with the outer lipid layer, which would then cause rapid breakup time. Non-invasive breakup time would being an indicator of that, which would then drive hydrophobicity on the lens surface, which would eventually lead to discomfort, typically with continued wear towards the end of the day. So, I have this global sense of what happens when things go awry, and I have great faith in technology that we have available today to prevent that.
Mm-hmm. Right.
I'd say data like the non-invasive breakup time changed the way that I think about that tear film, say, from lens forward, okay, the pre-contact lens tear film. Because in the past, we always think of T-butts as being, putting fluorescein in and looking at it. Of course, to do that with the contact lens in place, we either had to use high molecular weight molecules. It starts to become a little bit of a nuisance. We stop doing it. Or when
Take
we
the
do
lens
it,
out,
we're having
and
to,
then
exactly.
what does
Then
that
what do we
mean?
know? I've
Yeah.
messed with it. I'm back to my uncertainty principle. What am I really measuring? And while I obviously don't do it in office, it doesn't mean that the data isn't something that we use to draw conclusions,
Right.
as you were alluding to. It's one of those things where we're looking at it and going, okay, now, how can I apply this? How does it change the decision I'm making that matches the patient best? And to me, I stopped thinking about that lens as something that is discrete. It has to play ball with everything happening here, particularly when, if you think of it as and forgive us for going back to the 3 layers, but if we're going to have a mucin layer and an aqueous layer and a lipid layer, if I have something that loves lipid, it's flipping this tear film upside down. I've got a little mini tear film over the contact lens.
And maybe,
and if it's
maybe
pulling
under
lipid,
too, we
now
really
we're
don't know.
exactly. And so it causes me to change the way that I'm thinking of that lens, and also patient complaints, because they've told us over and over again, dry, 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 and we'll even fall for that. Oh, yeah, if it's dry, I should treat your dryness, and instead we've got an ocular surface issue or a anterior surface of lens issue.
Very good. Do you have any comments
Anything to add
yeah,
after
to
all
add
that?
on that? They've kind of, yeah.
Well, what I would add is that it gets you thinking about what is in front of that contact lens, and it gets you thinking about the interaction it has. So it gets you thinking more about the technology of the lens
Yeah, right.
and how
Right.
it can impact that.
So do you
So for
wanna
me
kinda-
personally, it drives me in that direction.
So this particular lens has HPMC surrounding it, and it also elutes components that could be viewed as beneficial to the tear film. And Art mentioned the lens should not disturb the normal, I wrote down, disturb the normal tear film structure. So when you have a lens that has this, this technology, which this lens does, you feel that that's, adding, you don't want to disturb the tear film. So let's talk about how it could add to the tear film, or, you don't want to detract. So what kinds of things could you put in the lens? Is this lens doing that and adding to the tear film? Do you have any thoughts on that? Put you on the spot down at the end
I
down
know,
there.
right? When I look at the science, and I just think it's amazing that they've got the PVA that's cross-linked, and then they have the unincorporated PVA, but it's a very large molecular weight. So it's not going to come out at once. It's going to come out over time with that friction and that shear force of the lids. Meanwhile, we've got the PVG, or the PEG, which is a small molecular weight, and it's going to come out very early on. As far as contaminate's not the right word,
Yeah,
but
no, it doesn't,
but you
yeah.
said, does it,
Add
affect
to or
it
augment,
in a negative way? And that takes me back to the studies. Well, when you look at the non-invasive T-butt, and it's higher than every other one, even after 16 hours, and it's actually higher than the non-contact lens eye, then how could it be?
Right, so that supports the mechanism of action for you. Yeah, good, very good. Any other things to add about that?
Actually, it's, I have this consolidated view of the tear film, a unified view, if you will, and I recognize that the tear film is not just complex in its structure, but also very, very complex in its function on a moment-to-moment basis. For example, why do we blink so often? Obviously, there's got to be something beyond just clearing the surface of the eye and restoring the tear film. I think it actually transforms the tear film. I think the tear film, as a fluid, is non-Newtonian in behavior. In other words, it behaves in a non-linear fashion. And when the tear film was created, as it evolved, the structure facilitated that. So we have gel-forming mucins that actually add structure to the tear film, and as they're compressed with each blink, they actually transform in terms of their function and structure. And on uplink, the lubricity increases. When we put a contact lens in the mix, how do you create a contact lens that fortifies that? Because obviously if it's destructive, the patient's going to end up in worse trouble than they started with. They're going to end up, not only with end-of-day dryness, they're going to end up with middle-of-day dryness. I think we've all seen that over the evolution of contact lenses. We've had contact lenses that
very
were
good,
indeed
right.
problematic. So, here we have a number of agents that elute out. This strategy that is used in dailies Aqua Comfort Plus is really a very intelligent, very state-of-the-art strategy. There are a number of molecules that are designed to release over time, that are released with the blink, that fortify the tear film, that add structure to the tear film, and are additive rather than subtractive. And that's one very, very effective strategy. Another strategy is creating a contact lens with a surface that's modified, that could mimic the ocular surface, or there are other strategies. So we're actually looking at a number of different lenses that actually have very advanced strategies that I think really do make a difference.
And that's, this is relatively, this is good to point out, because I think that it's not just putting a piece of plastic in the eye anymore. It really, this lens has some very unique properties that allow it to, in my opinion, do something that kind of starts to be like prevention. So I view contact lens continuum, like we were talking about, the continuum is starting out with, and I'm a public health person by nature, the MPH, so primary prevention is starting at the very beginning to keep anything from happening long term. And so for me, something that creates this environment where it's sort of protecting the tear film, and I mean that on the day that you're wearing it, but then also over the chronicity of your wearing life. That if you start out with something that's going to be somewhat protective, that's keeping you from getting, problems down the road, and maybe you can't keep them from getting it all together because of life and their technology and their genetic components and the medications, but you at least can keep them in the best scenario for the longest period of time. And so I think we're going to continue to see technology, but that makes this lens somewhat unique to me in that it acts almost preventative.
But I agree, and I think the key is to kind of start taking that, rather than even first do harm, to taking the step you were talking about. Let's make you better than before. Not necessarily to the point that we didn't necessarily call it treatment, but to be able to say, not only did I come in and make this eye see better than it saw and corrected before, I left that tear film better than I found it.
Right.
And that's where success really builds upon itself, because the patient's comfort goes up. The patient's, once that happens, then it's magic, not just from a patient compliance standpoint and not from a practice management standpoint, although those will happen. But that's when that patient's happy. And that's what we're supposed to do.
And we know we're having problems because we see these patients that were happy teenagers and ecstatic, post-teenagers suddenly hit, 35 years of age, and then suddenly, well, I'm not wearing my lenses that much. So we know that it's occurring, and this type of technology is a critical first step in understanding and respecting the ocular surface and environment, and not only respecting it, but as you said, fortifying it and making it better than when we found it, which I think is great.
It's essentially like kind of using, mouthwash or dental floss. It's the kind of the preventative steps to, maintain, in my mind, contact lens wear. So it can be really targeted towards, I think we tend to target daily lenses towards those that are having problems. And in this case, I really feel like it's sort of a very early step in preventing problems down the road.
That is absolutely so brilliant. And one of the things that I've been talking about with a lot of different folks is this embracing of the dental model.
Yeah. And
the dental model is getting people to come back on a regular basis for prophylactic care, which we've really neglected as a profession. And you essentially
our care has been come for your routine eye exam.
Right.
Our view of that. So.
And not preventative, but just routine. And who wants to come for routine? Come for something that will make a difference in your life going forward. I think what you just said actually really resonated with me.
It's a kind of a different way of looking at things. For me, it's a new ocular surface wellness. We've been talking about that a lot at this meeting, and it's really starting to resonate with me. So why should we save the best for the problem when we can actually prevent the problem in the first place? It's such a public health concept that it's like, well, okay, I understand
and it's
that,
like a no-brainer. You go, gee, why didn't I think of that before? You know?
All right, let's see. So we've talked about vision and comfort related to the tear film. We've talked about the non-invasive breakup time. Are there any, just as a side note, are there any bits of data that would engage you further, that you'd like to see, just as a kind of a side note here, relative to this kind of lens or its properties, unique properties in terms of the material, that would convince you, or you think would convince your colleagues more about, or teach your colleagues more about the technology behind this lens? This is just a off the side comment, but we're here, so.
I think if you want a looking glass a little bit, we spent so much time chasing decay as the absolute, this was going to fix all our problems. Because if we had oxygen, what else did the eye need? And you think about it and go, that was an idiotic way to go. How in the world was that supposed to solve everything if we just shoved a bunch of oxygen through? And I think what we're finding is there's quite a bit of juggling that has to be done to make these lenses work and make the tear film function. And that's something that I think we'll continue to balance here, is making sure that structure and function follow each other. Vision of course, has to be optimized because that's fundamentally what our job is, I mean, whether we like it or not, if we don't deliver on visual acuity, it's not going to happen. Get that comfort, get that convenience, but being able to know that at some point we can stand in front of a patient and go, this is the grand unifying theory of lenses, I have this, and we're there. And I think we've definitely seen from a tear film standpoint, our understanding and our ability has taken a huge jump forward.
Certainly, if the tear film is stable over top of a contact lens, your vision is going to be better. We keep coming back to the vision, which I think is important to note.
Well, lubricity is another issue.
Yeah,
that,
we have to, yeah.
Which
Would you like to talk about that a bit?
Yeah, we actually haven't spoken about it, but, one of my heroes, and I know, probably everybody's hero at this table is Donald Korb, who's probably one of the greatest observationalists in the history of optometry. And one of the things that Korb talked about not long ago and has gotten interest in the beginning and then sort of waned, and I think it's coming back around, is lid wiper epitheliopathy. So we look at the consequences of...
Do you want to just...
explain what
explain
it is?
Yeah.
Essentially, the lid is, like everything else in the body, has specialized areas, and it contains an area of stratified squamous epithelium, a type of epithelium that's designed to put up with abrasive forces. And that little strip, very much like a windshield wiper, sweeps up and down over the surface of the eye, gliding over an area of compressed liquid, hopefully never touching the actual surface of the eye or a contact lens. And in a normal patient with no issues who's comfortable, the lid wiper never really touches tissue. In a patient where forces or lubricity or other factors break down and the lid wiper becomes abraded, they end up with damage to the epithelial surface, which has very, very high correlation to comfort. And it's one of the few things that we have that shows very, very high correlation to comfort in both patients who have dry eye and patients who are contact lens wearers who are having comfort issues.
And Donald's first work on this was in the contact lens wearer with discomfort.
Correct, right. And in fact, I refereed that article, and it was one of the articles I could find absolutely nothing wrong with.
Yeah.
It was absolutely
Nice.
a thing of perfection. So we look at the technology. So if you're designing a contact lens and you're using advanced thinking, why not design a contact lens that actually enhances lubricity? So now this lid, which sweeps up and down thousands of times a day, glides over this frictionless surface. And I think the tear film is adapted to do that by itself. Contact lens certainly can alter that, so why not fix that and address those issues? And indeed, this type of technology does. So we see a lens that actually has enhanced lubricity, and I would venture to say that lenses of the future, newer designs that are coming out, will actually address this in even greater, to a greater extent.
And we talked a little bit earlier about how, the shear forcing of the blink, it sort of activates the release of this moisture into the tear film, which in theory would, keep that moisturized. And, for those of you who haven't looked at that or measured that, with some dye in the eye, I mean, it is quite obvious the extent of the staining can be really very visually notable. Now, I would venture to say many of our colleagues don't ever look at it. But if you have a symptomatic patient, you will find it. I am sure of it. And there's a mechanical bit to it because of this lubricity.
And if you think about the shear force of the blink, in my mind, it transforms the tear film. But if you can use it to actually transform the contact lens to release wetting agents and stabilizing agents, it's essentially using what nature designed to make the tear film more effective to make the contact lens more effective. So to me, that's brilliant, intelligent design.
Yeah. Anything else to add on that? No, it was all good. Let them do it, right? All right. So, with that, we hinted at the concept of compliance earlier. So I'll direct this one towards you. With this lens, over the course of a day, you are going to shear off the good stuff, right? It's going to do what it's supposed to do, enter the tear film. It can last for hours and hours, full day's worth of wear time. But then at the end of that day, it needs to be replenished with a new lens because it's finished its life. Have you utilized this in a way to promote compliance with any of your less compliant patients to ensure that they're not using the lenses, like you said, the cheapest way to be to save money on on lens care is to just never
abuse it?
Yeah, to abuse it. Have you utilized it that way or thought of it that way?
It's one of my favorite things about the
Great.
lens
Great.
because you'll have patients come in that say, I tried to use it. I tried to reuse it. It wasn't as comfortable, or it fell apart when I tried to clean it. And I like that, because the last thing I want to do is for them to go out and buy a 90 pack, let's say, and wear them for a week or two at a time, and I don't see them for 5 years.
Right.
Because they just hit the jackpot.
Yeah.
So I love that it is a unique material, that is a single-use material and is not used in any other wear modality.
Yeah, that's nice.
And that functionally, it functions as a single-use material.
So how does that discussion go with your patients? I mean, I can see where it would go, where they would be kind of like, huh. I'm thinking in their mind, maybe not, verbalizing the fact that, well, now, I don't know that I want that one because I can't be bad with it.
Well, what I tell them
Do
is
you get that?
that's what makes it so comfortable for that day. It's the fact that it has these extra weighting agents that are going to be released on the surface during that first day. You want something that has extra special characteristics like that, and I don't find that to be an issue.
That's good.
I found that the trials are really strong. One of the things, someone who is bent on being non-compliant is going to be non-compliant. So we're not going to undo that by an explanation of triple mechanism lenses and material science. Most of those patients are not overly aware of material science. They don't realize just how complicated it is.
They may not be the ones that they would find a way to not be in a daily lens anyway, wouldn't they? Probably.
I think one of the things that really delivers, though, is for those patients when you go, let me put this in, because there is, while I'm not a huge fan of insertion comfort, if we don't deliver insertion comfort, then the patient made up their mind. So while for us it doesn't necessarily help us make a lot of long-term decisions in what we're going to fit or not fit, for them they are forming opinions very rapidly. It's their first impression.
Right.
And so when that lens, if we go, well, I'll tell you what, let me give you this. Let's put this lens in and see how it does. And we put it in, it feels good, they see well, it's comfortable, and then we start talking about why this is important. And that non-compliant patient, while they are trying to maximize their how far they stretch things, they generally are not willing to put their vision at risk. Very few people really go, oh no, I was really hoping to have a corneal ulcer this year. I had one a few years back and it was great
Really
fun.
comfortable, yeah.
And it was, they
That's
want to be
a real
good,
thing.
and it helps give them, it helps motivate them to understand that this doesn't have to be an inconvenient, terrible thing to do. We can make me happy and you happy. And I use that expression, hey, look, we got to meet in the middle on this. You got to stop what you're doing, but let me make it better for you.
See, this is actually perfect, because this is going to be like a concerto. It's going to be like a piano going to, high, mid, and I'm going to go with a much lower note. I never, ever talk about the nature of this lens self-destructing. I just don't even bring it up with patients. And the reason why I don't is because I don't want patients thinking that their compliance should be based on a design feature of the contact lens, for several reasons. Number one, I may decide to use a different lens at some point in the future that doesn't do that, so I don't want them in the modality of making a decision based upon lens performance. I want them to make a decision on, number one, my authority as a prescribing doctor, number two, upon the logic of why I prescribe the lens for that wearing modality, and number three, because it's in their own best interest. If you don't make it visceral and make it in their own best interest, I think the patients are not going to comply. So the fact that this lens actually does have the capability of becoming less comfortable over a very short time is great, because there are non-compliant patients. So, I sort of nod to, your approach, where you're saying, this should be to maintain their health, and this is a major factor. But my concern is that a lot of our colleagues are really relying on the design of the lens to do the work that they should be doing in controlling the patient's behavior. We've given up on compliance, and that is tragic. We should not give up on compliance, because we have the ability to change patient behavior. And we're going to see lenses with different characteristics as time goes on, and we better get really good at ensuring compliance, because that's what we do. That's one of our jobs.
And interestingly, it's one of the largest areas of contact lens research is compliance. Well, how bad patients are really, because I think we're all shocked by that, which we shouldn't be, because we're the practitioners. And just how much work is going into trying to focus on improving compliance. And a daily lens is certainly a nice way to hopefully have some compliance, because it's a daily lens.
And there is a couple of little things that I found, and maybe have something to add to it, that we can always take away something from these get-togethers. But there are certain patients that then don't react quite as well. First responders. We have a couple of firemen that I have that are horrible abusers, and I thought, you know what? I'm getting my stick out. You're going to a daily. And one of the things that did not work overly well with them is I didn't let them know to expect that this lens won't let them push quite as hard as they want to. When they're doing a double, they're working 48 hours,
Right.
and we were starting to cross. But it's as easy as saying, make sure you keep some spare lenses with you.
Right.
And they understand daily,
Yeah.
not shift-wise, nothing else. And
Nurses
understand-
would be another, the same or doctors
Great
that are on
example,
call,
someone
yeah.
working greater than, if they're working 24 on, 24 off, that's just one of the things that they need to account for.
Right. Yeah, that's good to think
And
about. Mhm.
Art, I don't tell people that up front, but
Oh, no,
she
I didn't, I
she
didn't,
has,
I didn't think that.
yeah, I don't discuss it unless they come in saying, as a complaint or an observation. But you had mentioned people who want to be non-compliant are going to find a way not to be in a daily lens anyway.
Probably.
And I agree
you
with
think
that,
that's true?
but I also think it's a great tool if you have someone who has been very non-compliant to say, all right, this is over.
Yeah.
You know, you have consequences from that. I'm seeing ocular surface changes, and you see the redness. We both agree that this has to stop. And in order to get you the quickest relief and the quickest recovery, I am going to put you into a daily disposable lens.
Well, I think-
Hopefully
So they're
they'll
also
love
a
it.
good
I mean, 'cause they're
candidate
very
once
convenient,
you-
right? And that's what
yeah.
they're wanting.
Once you get through to them, they're also a good candidate.
Well, I think, we're actually saying the same thing. I mean, you're really discussing a feature set of the lens, which I think is important. We need to understand how lenses perform, and I'm basically discussing, how I think as practitioners we should work. I don't doubt, I know you're a good practitioner, and I know you influence patients really effectively. That's no surprise to me at all. So my guess is that you do pretty much the same thing I do. I just want for our colleagues to really highlight the importance of not relying on the modality or the lens to ensure compliance. We're never going to get 100% compliance, but if we don't try and we don't understand what motivates people, which is their own emotions, the limbic system, the visceral aspects of it, what's in it for them, if we can't convey what's in it for them based upon our own interaction and relationship with them, we're never going to be successful at assuring compliance. And then suddenly we're going to find ourselves with new modalities, new lenses, where compliance isn't assured, with advanced technologies like this, and we're going to lose the ability to do that. It's going to fall out of favor with us, and we're going to get unpracticed at it, and that's something we need to practice.
Well, patients are going to, insertion and removal still happens with the daily lens, and you still have, your hands need to be washed and some of the same issues relative to compliance that we talk about with all of our, modalities that our patients wear. All right, well, we have one final section to talk about, and that's really how the contact lens interacts with the ocular surface environment. So we've been talking a lot about how it interacts with the tear film specifically, but now I want to and we talked about lid wiper a bit. So how does the lens interact with the lid, or what are the components of a patient, the whole ocular surface environment, followed by what are some of the manufacturers doing about this, and what could be done to improve that through either lens design or other types of technology with the lens. So it's kind of our last segment here. We did talk about lid wiper, but do we want to extend that further to talking about other issues of the ocular surface and the ocular surface environment? I'll start with you. You started with lid wiper, so let's
Okay.
globalize this a bit.
Well, let's start from the bottom, and we'll work our way up. So we recognize that the tear film isn't liquid. It isn't just mucin. It isn't just lipid. We recognize that it's a coacervate, a complex gel, a viscoelastic gel. But we also have to recognize that it's a very, very thin film, and this contact lens is stretching it. And we have a corneal post lens, and then post-lens pre-surface layer of very, very thin tear. And so we have to actually recognize those two very, very different zones. So here we have transmembrane mucins that anchor the tear film in place, and then that sort of blossoms into this glycocalyx linked gel-forming mucin layer, which is aqueous, and that has to support the structure now with a lens in place. So we have to make sure that the lens surface doesn't interfere with that, doesn't disrupt it, doesn't rub or abrade the surface of the cornea, so it basically helps stabilize that layer. And at the same time, we also have to be very respectful and very cognizant of the fact that now we have this outer layer of gel-forming mucin, which transforms into phospholipid, which then transforms into this fine layer of nonpolar lipid, which serves as a moisture barrier, which has to remain intact in order to prevent the lens from being exposed to the atmosphere and becoming hydrophobic. It sounds very, very complicated. It's really not that complicated. The lens can't mess with stuff that's already there. So we don't want a lens...
But that stuff that's there can interact with the lens. So
Correct. Well,
Yeah.
and we have strategies, and in fact, we talked about it before we started. We have strategies where one company, and I won't mention names, came up with a concept where they created a surface that became increasingly hydrophobic with time to maintain moisture content within the lens, forgetting that this hydrophobic surface exists within a very hydrophilic environment. To me, that makes absolutely no sense. So hydrophilicity is critically important. That's number one, and synergy and with the entire tear film. We don't want a lens that's going to literally suck lipid out of the outer lipid layer, because suddenly now it's competing with meibomian gland production for producing enough lipid to maintain stability of the outer tear
Yep,
film
and
layer.
we're back to
So
stability again.
stability at all costs. That's really the
So
key
what other
mantra.
sorts of, if you were like pie in the skying, and thinking about manufacturing or lens materials, I guess we'll move on to, you think, we'll pass it on here. What kinds of either design by, it could be you say edge, it could be you say lubricity, it could be you say, different front and back or anything. What do you think would be
And that's the
cool
trick.
things coming,
What would be the thing to do? I
Yeah.
wish I knew. I would be a much better investor. It becomes being, and while you say you can't be all things to all people, the lens has to be. It has to be ready for, what about a hyperosmolar surface? What about, there's certain systems that I agree just don't necessarily work. Predicating function on failure. If we say, let's make a system that when it breaks will fix itself, that's the mentality, but why not make a system that doesn't break? Now, cooperating with everything, like you said, is the probably most difficult thing to do. And I don't envy the materials people that have to do that, but luckily that's not my job. My job is to apply what they come up with and make it do better. And I think it would be great to have a lens that doesn't decrease breakup. Why not have a lens that increases breakup? Why not have lenses where we can transmit more oxygen? One thing we haven't spoken about much.
Do you think we need more oxygen?
Possibly. It depends on the lens we're talking about, and depends on the wear times the patients
Right.
are really putting through. How often, and I don't know the answer, how often are they abusing this daily? Are they falling asleep and changing the next morning? That's a very different thing. And it's going to be very dependent on just how creative they are with their non-compliance. And I think that's one thing that is truly bottomless. They can think of everything, even
Yeah.
the things we didn't think
Well,
of.
sometimes I think we
But
talk
even
about the
allergy.
lowest levels of oxygen needed. Why do we focus on the lowest levels? I mean, should it be, minimum doesn't seem good enough to me. I mean, so.
If we're seeing morphology changes long-term from contact lens wear, then we're not perfect yet. If something's changing, if you can look back and say, you were a contact lens wearer, weren't you? And they go, oh yeah, a long time ago, used to get in trouble for that, I can't wear them anymore. And now that's an opportunity for us. Why can't you wear them anymore? Oh, my doctor told me I couldn't. We still hear, I have astigmatism, so I can't wear contacts. So we're obviously not doing a very good job of getting our message out. But even the allergy wearer, the patient wearer, I think a lot of times we're so working within our rut, so to speak. We haven't looked up at what the other things that we can do. I have a handful of patients that we've started
Yeah.
moving them over. They wear dailies part-time. Not part-time wear, but they're usually
Part-year wear.
Yeah, exactly.
Yeah.
So when they hit seasonal times where they're going, I am going through this lens very quickly. No problem. We're going to translate over here. But then they prefer, usually because it's a little bit of a value prospect, to go back over to a monthly modality for the other time. I have no problem with that. And adapting that turns out for them to be more convenient and more cost-effective. And the lens lasted the way that they
So that's
wanted it to last.
a different take on the lens in the ocular environment. Okay, the allergy season is going to come. The ocular environment is going to change. This might be a modality that supports, for a period of time in this otherwise normal person, a change that's more successful for them.
But that was the thing of beauty. I mean, what you
Yeah.
just said was really spot on. we choose the daily modality when the patient gets in trouble. In fact, the patient would choose it themselves. I mean, I had the exact same experience back in the day where we would use conventional lenses, and I would put patients into, in fact, I would, before we had daily disposables, I would negotiate with them and increase their replacement frequency and then extend it on the other end, because during allergy season, we wanted to replace those lenses more rapidly. We shouldn't really forget the utility of a very wet surface daily disposable in an allergy patient. It's a godsend for them.
Right.
It allows them to wear lenses when they couldn't do it before.
Well, and
So
you're
you said that
eliminating the
clean, wet,
stuff.
fresh lens
Exactly,
ready to
and
go
it
every
comes
time.
back to that hydrophilicity of the lens and maintaining it, because if you've got a dry spot on there, it's going to pull the lipids into it, and then it's just going to create a snowball effect. It's going to be more dry, more lipid reduction, more instability.
And more
in the
allergens
presence,
depositing on it as well,
exactly,
too.
in the
Attaching.
presence of high allergy.
And then the lid gets involved. Once the lid's involved, now it wants to be more involved, and
But-
this becomes a vicious cycle.
Exactly. What I like about what you said is it's not ideal. You would love for them to be in dailies every day of the year, but it was an opportunity to tailor your care. And so it really creates that customer advocate and evangelist for you, because they were listening and you were listening.
Oh, he is an evangelist.
Part-time.
So I hear a lens that's wet seems to be a strong desire, one that provides good vision, something that's lubricious, something perhaps ultimately that might enhance or make better the tear film in terms of the components and unique, complex, what did we say, elegant and complex nature of the tear film. We like the concept of a stable tear film. It's very important. We think it's important to us. It's important to our patients. And so I think, we've hit, those are the things in our nirvana of a lens, and I think we'll continue to see some more of that as we go through. So we have a few key things just to summarize. So I kind of did my little summary there, but Art, do you want to maybe just give a couple notes on the importance of the tear film?
The importance of the tear film. Can't live with it, you can't live without it. No. Actually, I think I'll narrow it a little bit. I think respecting and understanding the tear film is critically important. Obviously, the tear film is what stands between the surface of the eye and the outside environment. The body's all about protecting itself and maintaining itself and survival. So the tear film is this, as I said, as you just said, very elegant, just beautiful, complex, rich structure that allows us to interface with our environment with the most critical sense that we have for our survival and for the enjoyment of what we see. And the beauty of a contact lens, as envisioned by Wichterly and so many people that have come before us, is to enhance that. The daily disposable is the perfect embodiment of that dedication to science and clinical practice. To me, it's an inspiring moment. The fact that we have contact lenses that elute complex molecules that literally fortify and stabilize and respect a tear film is great. I know what's coming, and I know our colleagues are going to be very excited when we look at how we've captured nature and we've transformed the surface of a contact lens to mimic the surface of the eye, and it's in its elegance and its beauty. So to me, in just a few years, I think the vast bulk of what we're fitting will not only respect the ocular environment and embrace the tear film gently, but will also pretty much replace everything that's come before it. I think we're heading towards a daily disposable world, and I think it's going to be an incredible ride.
Yeah, technology will take us there. He stepped off the tear film and a little bit into the tear film contact lens interaction, which is what I was going to ask you about. So I want you to kind of maybe comment on that. Anything you really thought was remarkable here today, but then I have one other comment there. I've always thought that contact lens, the most ultimate contact lens experience would be to have no experience, no awareness.
Right.
So perhaps that you can kind of weave that into your,
The whole con.
yeah,
Just that easy.
just that easy, I know.
I think
Be
looking
brilliant.
at the interaction of this tear film, again, at just how dynamic it is, unbelievably complex, just ridiculously engineered in the way that it works. Yet, at the same time, we're going to go take something else equally complex and then start to measure the interactions between these things. Understanding all those interactions is going to be another continuum. It is not something where we will have a 3-step process and a dotted line to follow to know exactly how it's going to behave. It will vary, and it's going to vary by patient. It'll vary by time of year, by everything from meds to hormonal changes to weather changes to what the patient has come up with during this time. And I think what we have to learn to be is responsive to that as practitioners. Looking at the tools in our basket, I think we've got some things coming that are going to be very exciting, that are going to be fantastic tools. But that tool sitting there without a carpenter is not going to do anything. We've got to pick it up and use it. And that's where I think the challenge comes. If you always use the old tool because it's old faithful, then you never stepped into what you can really do next. And that's where we have to get. And patients may go there without us if we're not careful, because when our iPhone and contact lens envy, as it moves on, if as practitioners, if we're standing in one spot, our patients may suddenly find other practitioners that are willing to take them to that other level and introduce them to technology that they don't know about yet.
Or even worse, a vending machine. And that's why we so need to differentiate ourselves, embrace this technology, understand it, and communicate it, because that's what bonds us to patients.
Well, so what's left for you is blink-activated matrix, but I'm going to let you summarize whatever you'd like, because these fellows sort of did the same, so.
Well, you'll be good with
She was
blink-activated
most
matrix.
eloquent in describing
She
the
just said
technology of the
matrix.
lens, yeah, she was.
Well, you said earlier that the tear film is so complex. It sounds like it, but it's really very simple. And that's how the blink activated matrix is. You know, you think about how incredible that technology is as far as having that variety of molecular weight and being able to control to some degree when it's released on the surface throughout the day, and how that comes in with the other wetting agents and the PEG at different times. It's very beautiful and eloquent. Yeah, I lost the rest of my train of thought.
We
It
can only
is-
get our patients to be as passionate about it.
Yeah, right.
Well, you're talking about
So-
the matrix, talking about the hyper-reality of it. No, I'm just kidding. It's just, I was going in the wrong direction. I'm sorry. Go back on target.
Well, I think, oh yeah, go ahead.
No, I found it. It came back. When you think about it, you say it's very complex, but then it's simple. It's about the sizing and the release. But you think about science and how long they wanted to have a medication transport system, and this is really
It's
one
the
of the
beginning of
first
that, yeah.
successful means for that, and what that means in the big picture, and platform-wise and opportunities that it opens, then you realize again how amazing the technology is.
Yeah.
And so I think
Yeah,
you just kind of come full circle.
We didn't really
when you
talk
look
about that
it.
at all, but I think that's going to be we're going to see that. And it's not just going to be a lens soaked in a drug and put on the
Mhm.
eye. It's going to be
Right.
something much more elegant than that. And it probably is really going to have the ability to impact our patients in such significant ways. So, yeah, I think that's a really nice thing to end on. So I appreciate that.
Yes.
All right, well, I thank you for all of your time. But before we end, I want to make sure that we've covered everything, because we can go back and highlight anything you'd like.
No, I think you guys hit on all the major points. I think it was very rich content. It was kind of a free-ranging conversation. I thought it was wonderful. The only thing I would ask is, just for a moment, if you wanted to touch, we kind of went on compliance for a second, and we touched on the fact that not all the polymers necessarily are designed for single-use compliance. Some of them are reused from previous technology. So if we could just kind of talk on if you see that certain lenses do a better job encouraging compliance within dailies themselves. You know, there are certainly those patients who, if you prescribe a daily, they'll use dailies with them.
You sure you want to go down that road?
Well, no.
We don't have to use it.
You can always edit it.
Okay.
Just for fun.
Okay, Art's like, I'm ready, bring it on. Okay, Art, go ahead.
Can you go ahead and state the question, though, just so we have it on tape?
Yeah, what was that question? No.
Let's
I
talk a
know.
bit more about compliance with the variety of daily lenses that are out there on the market.
Well, actually, this would, yeah, actually, so I'll add my thoughts. Engineering a contact lens is a very complex process, and we're very, very fortunate that we have a number of scientists involved in this area that are absolutely brilliant. In fact, some of the most brilliant people I've ever met. And I think what's happened over the past few years is there's been a move towards a sort of functional approach where the structure of the eye has been looked at very, very closely in designing the contact lens itself. And it's varied from company to company. Some companies have preferred to rely on older technology. For example, we see a daily disposable that uses a surface that contains phosphorylcholine, which is a naturally occurring compound that facilitates lubricity, but has a relatively prolonged lifespan and is not reactive with the normal function of the eye. And can be helpful for some patients, but certainly is older technology. We see intermediate technology where the concept, as I sort of alluded to before, is to maintain hydration of the lens at all costs. And so fairly advanced technology has been applied to maintaining a hydrophobic surface, thinking that it emulates the eye's natural character, when in reality it's the exact perverse of what you'd want in that environment. And then we see some of the new technologies that either mimic ocular function through acknowledgement of the surface characteristics and trying to emulate and mimic them, or in the case of the dailies Aqua Comfort Plus, elutes molecules that fortify and interact with the tear film to help stabilize it and fortify its function. But all of those have various lifespans, and in the case of the dailies Aqua Comfort Plus, we see a lens that actually has a relatively finite lifespan. So the lens maximizes its function within a relatively short period of time, consistent with the labeling of the lens, and becomes less comfortable as those molecules are used up and elute less. And so it has built-in compliance.
Post the recommended wear time. let's just say that.
Exactly,
Yeah.
post the recommended wear time. So it's really timed to not only maximize comfort, but also to minimize overwear.
Mm-hmm.
And then the dramatic oversimplification of that is the difference between knowing you're due for an oil change and having the check engine light come on. So patients know when they're due for the oil change, but they may need the check engine light to remind them that they've gone too far. And
I'm sorry, go ahead.
no, I was, from a technology standpoint and compliance, I think one of the things dailies present, especially headed into the future, where we're seeing a dichotomy in the branding, where we have a very wide range of price points, for lack of a better way to put it, when we're talking about value. And the patients need to understand that there are differences between these lenses, that it's not just 365 pairs of lenses thrown in some different boxes with some different colors on them, that there are major differences in the way that these lenses function, and that we've taken something here where literally its infancy began when dailies began, figuring out, hey, this PVA may be something that we can use, and then changing the technology and the way that the lens is manufactured, in the way what we're putting in it, and even in what it's packaged with, to be able to have what represents the far end of this true new technology that's really doing something different, not a packaging difference. And from a compliance standpoint, I think that's where we expect to see better results from compliance, because we're delivering. We're not just talking to them.
Well, we're headed towards creating a living environment, a living environment of a contact lens, which is going to have a finite best lifespan, but that should be worth health and comfort, that would continue to drive compliance, I would think in the long run.
Ideally, if the lens could explode after 24 hours, that would be great. Yeah, I
And
did.
then you wouldn't
that
even have to
idea.
worry about the compliance issue of taking it out,
Yeah.
it'd just be gone.
No, I did want to comment on one thing, because I wanted to add it on to what I said. Crystal said something that was, I think, just really extremely astute, and she said, it's really simple. And the truth of the matter is, to our patients, it
It
really
is.
is very simple.
Mhm.
I like perhaps waxing poetic and rather, especially without a lot of sleep, very lengthy poetic. But what Crystal said is really the essence of the equation for the patient. For them, it's very simple. It's trust, it's performance, it's compliance, it's keeping them safe. They sometimes forget that keeping themselves safe is something they have to be involved in. So that really resonated with me. I think it's something that I'll probably want to add to my comments. Sort of reflect what you said. It's simple, stupid to
Yeah.
the patient.
But I just, whereas we were looking at the non-invasive tear breakup values and thinking, yes, that indicates stability is really important to us as practitioners. We trust that. Maybe we don't do that, but we trust that. The patients then trust what they hear from us. And so that message that we give them is what they trust, and the simpleness of it is what they take.
Is
So,
really the beauty of
or
it.
the complex, however we distill that down to them to be meaningful from a compliance and otherwise standpoint is really important. All right, gang, do we get that enough?
Yeah, that was all.
All right.
Thank you.
Anything else?
So should we say something about Bausch lenses being toxic and poisoning people, or, something like
Those are
that?
those are the exploding.
Those are exploding.
Yeah.
Those are exploding. Those are the ones with shrapnel lenses. No,
I mean, I think we followed everything on here. It wasn't exactly in the right order,
I
but.
think that a lot of the organic conversation was
Yeah.
actually extremely.
Well, I
Can we wrap
actually,
it out somehow? Folks, thank you for joining us.
oh, yeah, thank you. Yeah, don't, yeah.
Addition, one more thing.
Sure.
Can we just very succinctly try to summarize the so what piece of it in 2 or 3 points? What if the tear film is not functioning properly?
You die.
How the,
Let's see.
just, the.
Do you
blurring
want
of-
us to talk about when the tear film isn't functioning properly?
Because of the disruption by contact lens, the blurring.
Well, that's a good
the
point.
dry
That's a good
spots,
point. Yeah, actually, we really
So
didn't cover that.
can
That's a good
wrap
point.
it up when
Okay.
we're editing them.
Why don't we have you, Crystal?
Okay.
Do you want to say a couple words on it? Because I think these two maybe touch.
Do we
Sure,
sum
do
it
you
up?
want to say the
Say it.
question?
Let's see.
Well, no, I could phrase it. What we talked about when the tear film works well and trying to keep the tear film working well. What happens when the contact lens interferes with normal function of the tear film? What's the patient's experience in terms of blurry vision? What's the patient's experience in terms of comfort? What's the patient's experience in terms of long-term longevity as a lens wearer
Right.
and a patient of yours?
Yeah, or even
You
just
really
the
answered the
yeah.
question
No.
in the
I know. Or
question.
how about?
That's what I do with my kisses.
Only you
Okay,
are.
this is
to
what
answer
you
a question
said.
in a question.
Sorry.
So say what he says.
So, looking at it from a slit lamp perspective and seeing the tear film break up, knowing that that's going to lead to more deposition, more friction, more dehydration of the lens, and consequently to the patient, you're going to have redder eyes, you're going to have days where you have to take them out in a quicker period of time than what they would prefer. And ultimately, with deposition, you can have the CLPC and other consequences, and then leads to itching and more patient symptoms. So there's a cascade of events that could happen, all because of a disruption of that tear film and not respecting that integrity and taking steps to maintain it.
Yeah, well, I think that we, inserting a contact lens into the tear film is a disruption in the normal environment, right?
Right.
So we all recognize that. And I think we talked quite a bit at length about the ways in which this lens helps to prevent that change in structure, right? Art, from what you said, you don't want to disturb the normal tear film structure or enhance that, so that we talked quite a bit about how it'll enhance that in terms of the special properties of this lens. But certainly there are many lenses. I mean, whenever you add a lens to the ocular environment, you're disrupting the ocular environment. And so anything that we can do as clinicians to educate our patients about that and make good choices or solid choices in terms of the contact lenses and materials that we pick, I think is really very critical, because it's like any time you put in a false knee, false hip, you're putting something artificial into a body environment, and anything you can do to normalize or maximize that environment around that lens is really critical. And I think we see that all the time in contact lens wear.
It comes back to kind of where the discussion started. If that tear film is breaking up, that patient's going to have to blink over and over and over to maintain stable vision. And that's not what anybody wants. They may not realize that it's not normal. They may not realize to complain about it, but it does affect them,
It impacts vision, comfort,
especially
and
at the
ocular
computer
health,
and
yeah.
with our mobile devices and all that.
And it compromises the way the system was built to work, fundamentally.
Right.
It was built to function a certain way, and we've got to maintain that as closely as we can.
right?
Well, and then on a more basic level too, your inflammatory cells and just the way that it's going to cause other issues.
Impact the ocular surface environment
Exactly.
as well. Yeah.
Mhm.
Right. So in health and
multi-levels.
hopefully not disease. There we go. All right, I got a signal that I think we did okay there, so yeah, very good. All right, everyone, I really appreciate everything, and you'll get a chance to see elements of the transcript and make some edits. Make yourself sound even more wonderful than you already did today. And I'm sure everyone in the room just thanks you for your time and being here and looking beautiful on camera.
Thanks for a
Yeah.
great job
Thank you. You
moderating.
did a good
Thank you very
job.
much.
Appreciate it.
Sorry, I kept tearing. I was trying not to cry. I was just like, this is going to get ugly quickly.
Was your eye watering?
I went through the grand
Oh, I
unified
drank
theory
2
of
bottles of water. No, this is the side that was tearing, so I thought if I just stay
Just
here,
kinda
it's
like
okay.
this? I didn't even notice.
Was it